Welcome to the Life Diagnostic webinar series, and this particular webinar is on therapeutic drug monitoring of antifungals. Today we're going to go over the basic principles of why we need to do therapeutic drug monitoring and which methods are available. We'll then deal with the particular drugs for which this is most appropriate, particularly Itraconazole and Voriconazole amongst the azoles, and then separately Flucytosine. So our learning objectives today are to understand the need for TDM when prescribing Itraconazole, Voriconazole or Flucytosine, to be familiar with their main indications, the formulations and the relevance of those for TDM dosages and key pharmacokinetics. It's also important to be familiar with the side effects and whether they're related to drug levels and what dose adjustments are recommended in patients who have high or low levels. And we'll also summarize and show you some full details of TDM methodologies, in particular a mass spectrometry measurement, but there are other methods which we won't show you in detail, but we'll discuss briefly. So there are many antifungals on the market. The last licensed antifungal in Europe and the States is Voriconazole, and the drugs we're going to talk about today, Flucytosine, was developed in the 1970s, Itraconazole approved in the early 1990s, and Voriconazole in 2002. So what are the main arguments for undertaking a therapeutic drug monitoring? The first is that there are important drug interactions which affect the bioavailability or metabolism of antifungals, and this is one of the ways of checking on that, particularly proton pump inhibitors and itraconazole absorption, and rifampicin or rifampin, which increases azole metabolism, resulting in undetectable levels. There are multiple other drugs that can do this, including antiepileptics. In some patients, particularly those on long-term therapy, the compliance with therapy is not great, and this is a means of checking whether patients are taking the medicine that is prescribed and, in particular, the dose that's prescribed. Severe disease may require higher levels of drug, and there's also a lot of pharmacokinetic variability in children and the elderly, and probably in obese patients, although this is less well studied overall. There's certainly variability in patients who are critically ill and those who have organ failure, and there are certain genetic polymorphisms which increase or reduce the metabolism of drugs, and notably with Voriconazole. So there are three broad approaches to measuring drug levels in plasma or serum. The first is a bioassay methodology, and this is cheap and simple to run, although you do have to have the relevant bioassay organisms and create the standard curve of the drug of interest. If you have dual antifungal therapy, then the other antifungal can interfere with results, but this is not true for amphotericin, which diffuses poorly in agar. And with respect to Itraconazole, which is often measured by bioassay, both the native Itraconazole and its primary metabolite, hydroxyitraconazole, are bioactive and can diffuse through the agar at different rates, producing effectively a dual result, and therefore you get different results of bioassay than you do with HPLC or mass spec for Itraconazole. HPLC is widely available, many drugs are measured this way, and it can detect multiple drugs in a single sample if it's set up appropriately, and here you can measure Itraconazole separately from the metabolite, for example. Mass spectrometry is a more expensive machine, and overall, therefore, it's a slightly more expensive method, but it can also detect multiple drugs in a single sample, and it's very sensitive and specific, and is the method of choice if there are a large number of samples coming through. The preparation for mass spec is also simpler than it is for HPLC. So let me take you through the different azoles, in particular Itraconazole first. So this is a second generation azole. It's a synthetic triazole. The molecular weight is on the high side for most drugs at 700, and it's structurally fairly similar to ketoconazole and quite similar to posaconazole. And this produces some common features with regard to its metabolism, although not all of them. The main indications for itraconazole are dermatological, including oral or esophageal candidiasis, particularly using the solution rather than capsules, vulvovaginal candidiasis, pityriasis versicolor, tinea corporis or cruris, pedis and manuum. The indication for itraconazole is increasing because of terbinafine resistance, onychomycosis, and various forms of aspergillosis, both chronic and allergic aspergillosis. For other systemic infections, it's indicated for histoplasmosis and coccidioidomycosis. It has a license for systemic candidiasis, although is infrequently used for that, although itraconazole is active against most species of Candida. And it's also used for cryptococcosis in some patients as primary prophylaxis or secondary prophylaxis, particularly if patients are at risk of another infection such as histoplasmosis or have a dual or triple infection. The therapeutic drug ranges that are recommended for itraconazole with HPLC levels are more than 0.5 and more than 1 if you have a systemic infection. And a toxic level is not clearly defined with a single value, but gradually increases as the levels go up. It inhibits 3A4 metabolism and therefore has quite a lot of drug interactions, and these should be checked before prescribing. The absorption is variable with itraconazole, with quite poor absorption in patients with mucositis and advanced HIV disease, and those on PPIs if capsules are taken. It's also better absorbed with food, and if patients aren't eating, then that can be a problem. The bioavailability of the capsule is about 55%, but it's higher with the oral solution at 80%. There's an important food effect and gastric acid effect with the capsules, but not with the oral solution. It doesn't get into the spinal fluid, although it has been used for treating some brain infections, but it's not the preferred agent. It has a very high protein binding, principally metabolized by the liver through CYP3A4 to, in part, hydroxyitraconazole, which also has some activity and is slightly more water-soluble than itraconazole itself. With lower doses, its half-life is 21 hours, but it's got a longer half-life with higher doses. And its excretion is through the urine and feces through its metabolites. If you look at its other key PK parameters, as I've mentioned, it's got low solubility and the absorption varies a lot from patient to patient. And it's got this important food effect with the capsules, but not the solution. And this half-life varies depending on the dose. The important side effects of itraconazole include nausea, vomiting, taste disturbance, abdominal pain and diarrhea. And the vomiting and diarrhea are particularly a problem with the oral solution and much less of a problem with capsules. It can cause a hepatitis and hepatotoxicity, although this is infrequent. In patients on long-term therapy, peripheral neuropathy is a problem, and some patients get headaches or feel dizzy. It can cause congestive cardiac failure and ankle swelling. It also can cause hypokalemia. Rarely it can cause a rash. So the arguments for itraconazole TDM were mostly conducted with respect to prophylaxis in patients with neutropenia, leukemia, and the capsules were not very well absorbed in these patients, and levels that were low, that is less than 0.5 by HPLC, were associated with a much higher mortality than those with a higher level. And when you look at that overall, because of the difficulties of absorption, only the solution had a significant impact on reducing the incidence of invasive aspergillosis. In work we published many years ago, we looked at patients with different levels and their rate of toxicity of all sorts, including not being able to sleep and headache and so on, and more serious toxicities. And those patients who had levels by bioassay of more than 17 had really quite a marked increased incidence of adverse events. So one of the other arguments for measuring itraconazole is to try to minimize these adverse events. So the recommended bioassay range is between 5 and 17, and by HPLC it's 1 to 3, and mass spec would be the same as the HPLC measurement. Because the half-life is long, levels can be measured at any point after steady state is reached through the day. There isn't a need to specifically measure trough or peak levels. If the level is above the range, then depending on how high it is, the total daily dose should be reduced by 100 or 200 milligrams a day. And it can take some days for that change of dose to appear in terms of blood level monitoring. If the level is below range, then compliance and drug interactions need to be checked in detail. The dose can be increased. If there are proton pump inhibitors or ranitidine, cimetidine, then those should be stopped. It's also possible to administer capsules with food or Coca-Cola or other acidic beverages because that increases absorption. And a switch from capsules to liquid can also solve the problem of low blood levels. The other azole that it's important to monitor and measure for TDM purposes is Voriconazole. The molecular structure of Voriconazole is fairly similar to that of Fluconazole, but it behaves quite differently from Fluconazole, as Fluconazole is mostly water-soluble and excreted in the urine, whereas Voriconazole is metabolized by the liver. Like Itraconazole, is on the WHO Essential Medicines list and is a very important drug for the treatment of invasive and chronic pulmonary aspergillosis. The drug comes as tablets, typically 50 or 200 milligram strength, but it can also come as a suspension for oral use, and it is also intravenous through a powder. And there are some generic formulations available, although the original product used by Pfizer. The therapeutic range is recommended to be between 1 and 5.5, and toxic levels with a higher rate of hepatic and neurotoxicity are associated with levels above 6. The enzyme systems that it particularly goes through are 2C9 and 3A4, but there's also a polymorphism with 2C19. It has nonlinear kinetics in adults and linear kinetics in children. The oral availability of Voriconazole is high at more than 90%, and it's not affected by gastric acidity, but it is recommended that medication is taken an hour before food for increased and maximum absorption. It's 58% protein bound. It gets into the spinal fluid to some extent, but certainly into the CSF and ocular compartments. And that it means that it is typically the drug of choice for CNS disease. To get high levels in the blood, a loading dose is recommended, particularly when intravenous therapy is recommended. The half-life varies a lot depending on the patient's metabolic state, but is typically 6 to 24 hours, and therefore twice daily dosing is the norm for Voriconazole. Very little active drug is excreted in the urine. So it's metabolized through the 2C9, 2C19 and 3A4 systems, and in particular 2C19, there's an important genetic metabolizer, and some patients are slow metabolizers and others are fast metabolizers. So in addition, patients who have cirrhosis or have drunk too much alcohol may be slow metabolizers of this drug, and very old people are also slow metabolizers of the drug. 3 to 5% of Caucasians and 15 to 20% of Asians, particularly Northeast Asians, that is from Korea and Japan and China, have genetic polymorphisms of the 2C19 and are slow metabolizers and may develop toxicity early in the course of therapy. You can see here an example of modelling of the levels in patients who are fast metabolizers or slow metabolizers, and there's really a very large difference in exposure, and this is the point of the genetic polymorphism. In addition, we also see a lot of variability from one patient to another, and these models just illustrate that. So some patients have really quite low levels and others have higher levels. Aspergillus is inhibited. It's a time over MIC drug, and so having enough Voriconazole to inhibit the organism on a continuous basis is important for continuous therapy. And you can see that some of the patients who are fast metabolizers don't achieve this through the 24-hour period. Patients who have levels above 6 tend to have toxicity, and those levels 1 or 2 have higher rate of clinical failure. So certain elements of the diet impact levels. So high fat meals reduce absorption. We recommend Voriconazole taken before or after a meal and not around the time of the meal. And gastric pH is not important. So several studies show a correlation between levels and outcome. In one prospective randomized study, which is an unusual design, patients who had the levels reported to the clinicians versus those who didn't have the levels reported to clinicians were more likely to stay on drug, and there were many fewer discontinuations in that group of patients. And the response rate was also higher in those who had TDM. And that's really because this is a very effective drug. And if there's uncertainty about whether patients are able to tolerate it or whether they're having enough drug, and a switch is made to an inferior drug, such as for aspergillosis anyway, echinocandins or amphotericin, this impacts on outcome. The most important side effects are nausea and vomiting, although they're not that common overall. Liver function test abnormalities do occur, particularly with high levels. Abnormal vision seen as a flashing lights or some other odd visual sensations are common, and some patients have photophobia and or colour vision changes. Over time, fair-skinned white people can get photosensitivity or photodermatitis and dry lips and dry eyes, and that can be quite a problem. If patients are immunocompromised, can increase the rate of skin cancer. Rare events include problems which can occur with almost any drug, including a Stevens-Johnson syndrome or cholestasis or liver failure. So here's an example of the impact of blood levels and neurotoxicity, which is manifest primarily as confusional states or very severe visual disturbances. And you can see that patients who had levels above 6 were much more likely to have neurological toxicity than those who did not. And if you also look at liver toxicity, there's a gradual increase in the proportion of patients with hepatotoxicity in those as the levels rise. So both of these are arguments for keeping the drug in the therapeutic range. So we also know that the outcomes are better in patients who have trough levels more than 1. Because this is a twice-a-day drug, it's important to measure trough levels if it's possible to do so. And trough levels more than 6 are associated with encephalopathy or confusion, hepatotoxicity, visual disturbance, cardiac and electrolyte side effects. So who actually should have Voriconazole TDM? So for prophylaxis, for which it doesn't have an indication, levels should be more than 1. And we normally recommend a trough concentration should be measured within the first 7 days after initiation of therapy. It's important to try to remonitor voriconazole levels if other drugs are stopped, particularly those that interact substantially. Some patients don't take the therapy very well, and then there are also concerns about GI absorption in some patients and potential laboratory or clinical manifestations, so patients with confusion or liver abnormalities, to ascertain whether those are due to the drug or some other problem. It helps with whether to stop the drug permanently or temporarily. So the level should be more than 1 to maximize efficacy, and if patients have very severe infections, particularly CNS infections, then more than 2, and try and keep the trough level less than 5.5 to minimize toxicity. If the level is above the range, then the general recommendation is to reduce the dose by 50%. If the levels are very high, that is more than 10, then consider an alternative antifungal or skip 1 dose and then reduce by 50%. If the levels are below the range, then obviously compliance and interaction should be checked and the dose should be increased up by 50%, so 50 or 100 milligrams twice daily if the patient's on oral. So a common change of dose is from 200 milligrams twice daily to 250 milligrams twice daily. If the patient's on a very high dose of 350 milligrams twice daily or more, then increasing the dose usually ends up with neurological toxicity, which can be motor or sensory. The dose should be also checked in the 5 days of a change in dosage, because that's important to get the dose right, given that the drug is not linear in adults. Now I'm going to move to the other azoles and introduce the LCMS assay, etc. Voriconazole suspension is not associated with adequate absorption in some patients, and it's advised to give this with a fatty meal, and therefore it has been of value to measure voriconazole levels in patients on the suspension. There's very little data on high levels of voriconazole and toxicity, but our own experience suggests that patients with levels above 3 are more likely to get some side effects. The voriconazole tablets are better absorbed than suspension, and therefore there is much less concern about low levels, although even in some children and some stem cell transplant patients there may be low levels in occasional patients. But it may be possible to reduce the dose if TDM is done and the patients have adequate levels. There's no guidance at the moment about his Itraconazole level and TDM. So now we're going to introduce and show you a video regarding an LCMS assay for measuring all azole levels in the same assay. This has been published and it is quite a useful technique for labs with the relevant capabilities.
The combined azole assay measures the level of the antifungal agents Voriconazole, Voriconazole, Itraconazole, and hydroxyitraconazole in patient plasma samples by liquid chromatography tandem mass spectroscopy. The analysis is undertaken to determine azole levels in patients receiving the drugs for treatment or prophylaxis of fungal disease. The results are highly specific and are not influenced by the use of antifungal combination therapy. This procedure is carried out in polypropylene 96 deep well plates. Polystyrene or polycarbonate plates must not be used. Timings are non-critical and will not affect examination results. Before you begin, ensure the daily mass spectrometer maintenance has been carried out on the mass spectrometer to be used. Collect your quality controls and standards from the fridge or freezer and print out a worksheet from your data capture system. External standards and quality control material can be purchased commercially and made up according to the manufacturer's instructions. Internal standards of D3 Voriconazole, D5 Posiconazole and D5 Itraconazole should be made up to 1 mg per milliliter in methanol. These are stable for 5 years in the freezer and can be diluted to create working internal standards as required. Inclusion of these standards mitigates against any matrix effects that might alter the ionization efficiency and adversely affect accuracy and sensitivity. A working combined azole internal standard, D3 Voriconazole, at 0.2 mg per litre is made by diluting stock D3 Voriconazole 1 in 5,000 in methanol. 1 mg per litre of D5 Posiconazole and D5 Itraconazole are made by diluting the relevant stock solutions 1 in 1,000 in methanol. D5 Posiconazole is used as the internal standard for hydroxyitraconazole. Working internal standards can be stored in the fridge and are stable for 12 months. To start the assay, label the plate. Follow the printed workout sheet. Write the well number to be used on the worksheet, starting with the standards, followed by the quality controls, and finally the patient samples. Vortex mix the standards and quality controls. Invert the patient samples and pipette 25 microliters of each into the appropriate well. A 25 microliter positive displacement pipette should be used for maximum accuracy, and the tip should be changed daily. The pipette tip must be washed between samples with deionized water, then methanol, then fresh deionized water. Using a repeat pipette and appropriate tip, add 25 microliters of 0.1 millimoles per litre zinc sulfate solution to each well to precipitate proteins. Followed by 100 microliters of combined azole working internal standard for further protein precipitation. Seal the plate with heat-sealed foil. And rub over the surface to ensure that the seal is complete. Vortex mix for 1 minute on a multi-vortex, then centrifuge the plate at 2500 RPM for 5 minutes. Place the samples in the auto-sampler of the liquid chromatography unit, ensuring that the correct mobile phases are loaded. Mobile phase A1 is made up of 2 millimoles per litre of ammonium acetate with 0.1% formic acid by volume in deionized water. Similarly, mobile phase B1 is made up of 2 millimoles per litre of ammonium acetate with 0.1% formic acid by volume in methanol. Put the azole column In this case, a Pharmacokinetics 2.6 micron C8 column, 30 by 2.1 mm with crud catcher guard, inside the oven and set to 40 degrees C. Load the correct azoles tune page on the mass spectrometer. The mass to charge ratio transitions used to measure voriconazole and D3 voriconazole are approximately 350 to 224 and 353 to 224 respectively. The mass to charge ratio transitions used to measure posaconazole and D5 posaconazole are approximately 701 to 127 and 706 to 127 respectively. The mass to charge ratio transitions used to measure itraconazole and D5 itraconazole are approximately 705 to 392 and 710 to 397 respectively. The transitions used to measure hydroxyitraconazole is approximately 721 to 408. D5 posaconazole is used as the internal standard for hydroxyitraconazole. The run can be analysed and reported against the internal standards. After the run, post-analytical checks should be done by a senior laboratory scientist. The quality control values should be recorded to check that the run has passed, and equipment maintenance records should be kept. This is best practice for column and assay care, and should include back pressure on the UPLC, area for the top standard, and retention time. Once these checks are complete, the data can be entered into your hospital system to be reviewed by clinicians.
So now I'm going to address flucytosine. Flucytosine is a synthetic fluorinated analogue of one of the DNA bases, cytosine, and you can see the structure here with the very subtle difference between the base and the drug. The molecular weight is quite small. The perimidine is critical for DNA and RNA and other nucleotides. It was originally discovered as an anti-cancer drug and in high concentrations does have bone marrow toxicity. It's the only anti-metabolite systemic antifungal in clinical practice. Flucytosine is indicated in particular for cryptococcal meningitis in combination with amphotericin or flucytosine. It can also be used in severe systemic candidiasis in combination with amphotericin, and with the emergence of multi-resistant Candida auris and Candida glabrata infections, this is relevant. It's excreted in the urine, and so some people have used it for urogenital candidiasis, particularly with glabrata infections, which are fluconazole resistant. And there's an off-label indication for chromoblastomycosis and a few other rare infections. Most of the prescribing is oral through capsules or tablets, and there are a small number of generic manufacturers of flucytosine. Some countries have parenteral flucytosine and others do not. The dose is the same, but it's given obviously in a different route. So the standard dose now for cryptococcal meningitis is 100 milligrams per kilogram per day in 4 divided doses. Flucytosine has a short half-life, and so it needs to be given frequently, and this does cause difficulties, particularly in the outpatient setting. The older text suggested a dose between 50 and 150 milligrams per kilogram per day, but these higher levels are not necessary in cryptococcal meningitis. In children, the doses are the same unless you're a neonate, in which case slightly higher doses are required, and it's cleared fairly fast by babies, unless they're very premature indeed. Now, if a patient has renal dysfunction, it's very important to adjust the dose because the drug is almost completely excreted through the urine, and so there is a nomogram for this in terms of the creatinine clearance. This has been developed well in adults, but not so well in children. And so, although the individual doses are the same at 25 milligrams per kilogram per dose, the dosage interval should change so that patients get much less frequent dosing. So if you have somebody in overt renal failure, then it would be given probably once every 2 to 3 days, and it would be best to measure levels in those patients. Flucytosine is associated with quite a lot of nausea and vomiting and some diarrhea and abdominal pain. It can cause rashes, although that's not too common. And much less commonly are a whole load of other side effects. Some of these are probably attributable to the very sick patients in whom it's given, and the particular concerns that we have are thrombocytopenia, leukopenia, and aplastic anemia because of high levels of flucytosine. And that is exaggerated if you have renal dysfunction, and that may be exaggerated because patients are on amphotericin B. But flucytosine can also cause hepatitis and hepatic necrosis, and that's important. And some patients do have a sense of CNS toxicity, again, probably related to higher doses in most of them. So the indications for Flucytosine TDM are really renal failure and renal impairment in neonates, patients on renal support, which can include hemofiltration or dialysis, patients on ECMO or other filters. There are occasional patients with very short bowels and maybe on long-term total parenteral nutrition, and absorption may be an issue in those patients. And in patients who are taking flucytosine for long periods of time with a chronic infection, it's important or helpful to check that they have the appropriate oral dose. The reason for measuring flucytosine is because it has a relatively narrow therapeutic index, and the idea is to keep levels under 100 because above that you get liver toxicity and bone marrow suppression in occasional patients. And if you have levels that are too low, then there's a greater chance of resistance emergence, and as monotherapy this drug does induce resistance in Candida quite fast. So our plasma concentrations for optimal response are between 20 and 50 trough levels. The recommendation is between 70 to 80 peak and 30 to 40 trough. Similar levels in neonates, but slightly different levels. This is not well evidenced in terms of the precision of these levels, but it gives you a sense of what one is aiming for. And what we do know is that patients with high levels have more toxicity. So you can see this on the schematic here, where your peak level should be between 50 and 100 and your trough between 20 and 40, and really trying to avoid levels above 100 or levels lower than 20. This was assessed in one study in the UK, and you can see on this graph here that there was really a lot of variation. So only 21% were actually in the normal range. 41% had low levels, 5% undetectable levels, and nearly 40% had high levels. And neonates in particular had high levels more frequently than non-neonates. So flucytosine can be measured in multiple different ways. This photograph shows you an example of a bioassay plate being set up, and that's a common means of measuring flucytosine. HPLC is also fairly common. There are other methods, including a GLC, fluorometry, and enzymatic methods, and these depend on what's available in your country or in your biochemistry laboratory. Here's an example of a flucytosine bioassay plate, and the size of the zone represents the amount of drug that's diffusing through the plate. It's not set up in a way that you can determine the level without measuring each individual zone, plotting a normal curve, and then taking the individual patient samples, which are more obvious because there's precipitation of the serum around them with a sort of big white circle around the agar hole. Different bioassay organisms are used, and some of these can be resistant to other antifungals. So if, for example, a patient's on flucytosine and fluconazole, then the choice of organism would be a fluconazole-resistant Candida isolate, and then you could measure just the flucytosine, for example. Once the assay is set up, it's incubated overnight and then read the following morning, and the dynamic range of a flucytosine bioassay is between 12 and 200. So the British Society for Medical Mycology recommended some reasons for measuring flucytosine, and these are in this table here, and I've gone over these already. One of the key findings from the multiple very large studies that have been done mostly in Africa, but also Southeast Asia, of cryptococcal meningitis with flucytosine indicate that levels are not necessary to be measured in these patients on a routine basis, because at the slightly lower dose of 100 milligrams per kilogram per day, toxicity is infrequent. The only real exception to that is patients with significant renal failure, and some of these were excluded from the trials. So that's the group that may benefit from TDM. So in summary, itraconazole with HPLC, we're aiming for a level between 1 and 3, and with bioassay between 5 and 17. Capsules may have poor bioavailability, and there may be variations between one generic preparation and another, and factors affecting stomach acid like PPIs or rilidine cimetidine also can impair absorption. Trough levels of less than 0.5 by HPLC are associated with a high mortality or clinical failure. With voriconazole, the target trough level should be between 1 and 2, and more than 2 for severe infections. It has non-linear kinetics in adults, and there are slow metabolizers who have much greater exposure because they're a slow metabolizer. TDM also gives better responses and fewer discontinuations of therapy, and levels more than 5.5 are associated with neurotoxicity and hepatotoxicity. So with voriconazole, it's important to measure levels early in the course of therapy, and particularly from changing from IV to oral or with a change in dose. The target trough level for flucytosine is between 20 and 40, and levels above 100 should be avoided. The dose should be adjusted for renal impairment anyway, and TDM is recommended for patients with renal failure, neonates, dialysis, and those on various other forms of renal or other support such as ECMO, in patients with short bowel syndrome and those with long-term use.
Good afternoon. This is the fourth of a series of live worldwide webinars that we've been producing. And today's topic is therapeutic drug monitoring of antifungal drugs.
大家好，非常感谢大家来参加第4次网络研讨会。这次我们研讨会的主题是抗真菌治疗药物的监测。
My name is Malcolm Richardson. I'm from the Mycology Reference Center, and I have my colleague here, Sophia Hu.
大家好，我叫侯佳音，在曼彻斯特真菌工作。刚才讲话的是我的 Professor Malcolm Richardson。
So David, please, let's hear everything you're going to tell us about TDM, antifungal drug monitoring.
下面请David Dunning 医生为我们讲解关于抗真菌治疗药物的检测。
Thank you, Professor Denning. A very exhaustive, detailed overview of TDM for antifungals, and I think probably a lot of this material will be very useful for the Chinese attendees.
非常感谢Dunning 医生为我们做的讲解，希望这些讲解能对你们对药物的使用和监测有所帮助。
So, considering the size of a country like China, it's a vast country, one of the immediate questions might be how stable are antifungals in clinical samples, thinking of how long it might take for samples to travel a couple of thousand miles or 3,000 kilometers. How stable are these molecules before they reach the laboratory?
由于地理位置，中国非常地缘非常广阔，真菌药物在血液中的稳定性能持续多久呢？由于运输原因，可能会导致样品到达实验室的时间会不一定，所以药物在血液当中的稳定性非常重要。
A very good question, Malcolm. Thank you very much. Overall, these molecules are quite stable.
这些药物在血液当中是比较稳定的。
There hasn't been a very good piece of work documenting exactly how long a sample can be in transit, but we do know from our own work that 2 or 3 days in the postal service yields good and reliable levels in patients.
并没有很多研究表明这些药物在血液当中能稳定多久，但是根据我们自己的经验呢，如果样品在途中经历2到3天，结果还是相对稳定的。
Samples are stable if frozen, and they probably have a longer life if kept at 4 degrees, but even room temperature is adequate. Very hot temperatures should be avoided.
如果在4度左右，运输当中如果有冷冻性质会更好。如果在常温的话，2到3天也是可以，但是不希望有太热。
Okay, you've given us a lot of information about TDM for azole antifungals and for 5-flucytosine. But my question is, are there any indications at all for measuring the levels of amphotericin B in clinical samples?
你给了我们很多关于三唑类药物和氟包唑或者是氟胞嘧啶药物的检测。关于两性霉素B 的检测是否也需要呢？
Amphotericin B has very complex pharmacokinetics.
两性霉素 B 的结构相对于比较复杂。
It has an early high rise in blood levels, and then it gets redistributed to tissue, and there are two phases of that redistribution.
它进入人体后会迅速在血液当中的浓度升高，然后会到身体各个组织当中。
So measurement of a blood level is not useful and is not something we would recommend in any circumstances.
因此呢，我们并不建议测试血液当中的浓度。
So I think this question really is quite relevant for China and for the surrounding area. The question is, do you see a role for pharmacokinetics in testing, in treating patients with a chronic fungal infection, understanding, of course, that people do vary in the way in which they can metabolize some of these drugs?
下面这个问题呢，会对我们中国或其他周边国家非常有用。由于不同种族人群对药物吸收有不同程度的区别，药物基因检测是否有必要呢？特别针对慢性霉菌感染疾病。
So the biggest variation in levels is seen with Voriconazole, and one of the enzyme systems that metabolizes it is 2C19.
目前为止呢，对于氟利康唑的药物吸收是有明显区别的，特别是金烯19。
There are some polymorphisms in 2C19, and about 15% of people in China and Korea and Japan have a slow metabolizer phenotype.
然后根据这个基因呢，有15%的中国人、日本人和韩国人对它的吸收比较缓慢。
So these patients can have high levels of voriconazole and toxicity, and it's very important to measure voriconazole levels in patients when they start therapy anyway.
这些病人对于氟利康唑会有很强的反应，因为氟利康唑在他们血液当中的浓度会非常高，所以呢，定期的检测和密切的监测是非常有必要的。
Whether a pharmacokinetics measurement of 2C19 would be fast enough and accurate enough, I think, is not clear, but possibly in patients who are going to go through transplant or multiple courses of chemotherapy, then understanding that phenotype at the beginning might be valuable.
虽然药物基因检测的稳定性还有准确性，还有它的时效性，我们并不清楚。但是对于器官移植或者是进行化疗的人群来讲，做此样检测呢，会对治疗的过程会很有帮助的。
A very small number of patients have high levels and need very little itraconazole, and that probably goes through 3A4, CYP3A4. But that seems to be a rare phenomenon, and I'm not sure that pharmacogenetics is appropriate for that group.
对于 CYP3A4 的病人，有一些是用依曲康唑的药物。对于他们来讲，由于人群非常少，此项测试并不一定会有帮助。
So back to my previous question, one of my previous questions, the whole question about stability of antifungals in clinical samples.
关于前一项的问题，就是真菌药物在血液当中的稳定性。
And the long transit time in a large country like China.
长途的运输。
I'm aware of some work that has looked at the collection of blood from the fingertip, and then that can be dispatched and processed for TDM.
如果从指尖取血样，然后再经过运输呢？
Has there been any further work in this area? How stable are antifungals in blood, fingertip blood drops on a filter paper, for example?
药物在纸张上，血液在纸张上的浓度会持续多久呢？
I don't think we know the answer to that question. I'm not sure.
并不清楚。
Yeah, I haven't seen any work, but I would imagine they would be stable in a filter paper fingertip blood.
目前并没有很多的研究，也不是很清楚，但是我觉得它是相对来说比较稳定的。
Okay, right. Well, thank you, David, for that wonderful lecture, and thank you to the attendees. I think we've had a good question and answer session, and I'd just like to remind the attendees that this webinar and the previous 3 ones will be available on Youku, so they can be viewed at your leisure. So thank you everybody for all the hard work that went into making this webinar. Thank you very much.
非常感谢大家参加此次研讨会，也非常感谢Dr. Deming 和 Malcolm Richardson 对我们的帮助和讲解，希望大家都能有所收获。联合上3次和这次的网络研讨会都会放到优酷网站上，希望大家能有时间继续观看。如果你对我们有什么意见或建议，欢迎给我们留言。祝大家晚安。